Started. So, chronic illness, population health, and health promotion. It's a bit of a mouthful, but that's what's going to kick us off for this unit. So really it's going to lay a foundation which we're going to build on. Population health certainly is going to be a foundation, and chronic illness and health promotion is what we're going to really dive into a lot of depth over the next 12 weeks or so. Hang on, let's just check here. Yes, what a start, I agree. Thanks, guys. Okay, so just make sure this PowerPoint's working. And okay, so of course we always acknowledge the traditional owners of the land that QUT is on. These places have always been places of teaching and learning, so I'd just like to pay my respect to elders past, present and future. So overview, as I've just mentioned already, chronic illness in Australia, population health, and then health promotion. At the end, we'll have plenty of time for discussion, questions and answers. We can either do that through the chat, or if it's very orderly, we might try doing it by audio. We could be brave. We've made it this far. Now, I guess quickly for those of you who didn't make it to the orientation lecture, I do have an update that the IT team have assured me that the recording of the orientation lecture will be up today. So I'm hoping any minute now it'll be up on Blackboard. So again, thanks for bearing with me. I did everything I could from my end, but there was a glitch with the, because it was O week, they're not used to actually having lectures run and recorded in O week. So, but look, I did, for those of you who haven't seen it yet, my background, I've got quite a diverse background in terms of across acute and primary healthcare settings, mainly in mental health and palliative care, but I've also worked as an RN in general practice. So a lot of this content relates to primary healthcare and, you know, really trying to prevent and manage illness in the community before we get, you know, locked down in EDs or all of our hospitals for, you know, people presenting in really acute conditions and, you know, in crisis really. So that's a little bit about me, and I am passionate about this subject. So I mentioned in the orientation lecture, if you do find at times you might be struggling to connect the relevance, or, you know, you might want to be work in a particular area. You know, we're very acute centric usually, a lot of nursing students, so just try and bear with it, and I'm sure that at some point, whether it's in this semester or when you're out practicing as an RN, the penny will drop and you'll go, that's what Jason was trying to you know, communicate to us. You know, I see it now. One thing I mentioned as well is this partnership. So partnerships is a theme that, you know, it runs throughout this unit, mainly in terms of partnerships between we as nurses and healthcare consumers, but also in terms of partnerships between ourselves as nurses and our colleagues in allied health and medical disciplines as well. I did kind of make the point during the orientation lecture that I would like you to see this unit in terms of partnership. So the teaching team, there are a lot of really experienced RNs. We've got some nurse practitioners who are really advanced practice clinicians. We've got a lot of experience. So, you know, the team would like to share that with you. We're here to support you and we want to see you succeed. So if you can work with us, then we'll get a lot out of that partnership. So moving on now to chronic illness and disability. You'll notice that the textbook isn't just about chronic illness. It's called Living with Chronic Illness and Disability. So although we'll be focusing mainly on chronic illness and managing it and our role as nurses in supporting self-management, you know, so I won't be labouring on the disability aspect of it, but we do need to remember that that is strong, chronic illness creates disability. When we're experiencing chronic symptoms, that can really impact on our ability to function in life, our ability to work, to hold down a job, and all sorts of things in terms of quality of life. So just keep that in the background, that chronic illness and disability, and we want to minimise that disability, obviously. So chronic disease, there we go, we've got some blue. It's recognised as Australia's biggest health challenge, and it's not, that's not an exaggeration. Chronic diseases are the leading cause of illness, disability and death in Australia. So in 2011, nearly 90% of all deaths were associated with chronic illness. And we can see over the years, and that's why population health is the important perspective, is that, we've been very good at increasing our lifespan. So we're living longer, but unfortunately we're living longer with more illness. So our lifespan's improved, with the advent of antibiotics especially. So we're able to treat infection, whereas pre-antibiotics, if, you got a bad infection, often that meant you would end up dying. So particularly reducing the incidence of infection and infant deaths in the late 19th and early 20th century. So, like I say, we're living longer, but we're living longer with more, and not just one, but often two or three different chronic illnesses. And they can interact with each other. And then we've got polypharmacy issues with taking drugs to treat one condition, which then may impact on another condition. So, changing lifestyle is another important thing to consider in terms of how this change has happened and why. And lifestyle behaviour and lifestyle change is something that we're really going to actually talk about and focus on in this unit. So in terms of how we as nurses can work, not just through education, but work through partnering with people to kind of understand how our lifestyles really can bring about chronic disease. So what is a chronic illness? I'll just mention as well, chronic disease, you will see in the literature that the Australian Institute of Health and Welfare, or the AIHW, in particular, you will see different terminology. So you will see chronic disease a lot, and it's a very much a biomedical kind of approach to terminology. And so you might be thinking, well, my textbook says chronic illness, but yet AIHW is talking about chronic disease. What's up with that? What's the difference? Well, this is confusing. But in your textbook, in chapter 1, could you just mute, please? Thank you. So in chapter 1, the authors of your textbook do actually explain that they have chosen, Chang and Johnson, have chosen to use the term chronic illness over chronic disease. So they are used interchangeably. You could, from an epidemiology perspective or a biomedical perspective, they would talk more about chronic disease. Whereas nursing, often we take a more humanistic, more holistic approach, and so the authors of your textbook argue that they use the term chronic illness because it's more encompassing or more holistic in terms of looking at the lived experience of a disease. So chronic illness encompasses a lot of things like disability, which may not come, in terms of chronic disease, these authors argue at least that chronic illness is more broad and holistic in representing the entirety or the totality of, let's say, living with diabetes. So that's just one point of distinction on terminology that I wanted to get across. Your textbook uses the term chronic illness, and that's great, that's fine. So what are they? So chronic disease, it's a long-lasting condition with persistent effects, which as I've mentioned, includes disability. There are social and economic consequences, and these do impact on our quality of life. Chronic disease is increasingly common, and as we've said, it's Australia's biggest health challenge, so it's a growing priority. And we'll look at some of the models of care and some of the ways that the health system is trying to adapt to address that. Look, there are some major groupings or clusters of chronic disease. So I mentioned the Australian Institute of Health and Welfare, or the AIHW. They several years ago identified national health priority areas. So arthritis, asthma, cancer, cardiovascular disease, COPD or chronic obstructive pulmonary disease, diabetes, and mental illness or mental health conditions. So some more characteristics, how do we contrast chronic illness versus an acute episode of illness? So, chronic or long-term illness requires adjustment to the demands of the illness, as well as the therapies or the treatment. So these cause additional stress. So, for example, chemo. Sometimes the treatment causes a lot of problems, but you need the treatment to treat the condition. So this sounds really simple, but it's important for us to really understand that, chronic illness can really change the way you live your life. It can change your identity, your own concept of self, and the way that you relate to others. So look, chronic illness doesn't just resolve overnight, and often generally not cured completely. So the emphasis is often on management. With chronic illness, you can't get rid of it overnight, so you need to manage it and try and live with it as best you can. Some can be immediately life-threatening, so like heart disease or stroke, for example, whereas others linger over time and need more intensive management, such as diabetes. So most chronic illnesses persist throughout someone's life, but they're not always the cause of death. So, for example, arthritis, which even though it's debilitating often, may not necessarily cause death. So some more general characteristics of chronic illness: often they have a complex cause, usually multiple risk factors, and we're gonna talk more about risk factors next week. So these can be either modifiable or non-modifiable. The modifiable are generally behavioural risk factors, whereas the non-modifiable risk factors are, things like your genetics or your gender, for example. You can't really biomedically, if you're predisposed to, or let's say I as a male have more risk of prostate cancer than someone who isn't a male. As kind of obvious as that sounds, but that's just one of the biomedical risk factors that you can't modify. So long periods between the onset of the illness and actually feeling effect. So it can be quite a gap, quite a lapse of time. And so yeah, essentially it's long-term illness. If you were to compare, my mum, for example, went to ED yesterday because she had a fall and had a huge gash on her head. That's an acute episode. She went to ED, she had all the scans, and she was out of there after half a day. But that's not long-term illness, whereas chronic illness is generally, a key characteristic of long-term illness is, of chronic illness is it's long-term in nature. So hence the emphasis on, management. People are living with chronic illness for a long time, so it doesn't just go away. And one of the final general characteristics is functional impairment or disability. So I mentioned, these chronic illness can really impact on just being able to get up, get out of bed and go to work, or even just do simple activities of daily living that we take for granted. So a little bit on disability. So look, chronic illness can lead to long-term disability, or it could be short-term. So essentially, we're talking about loss of one's ability to function in their life and work due to psychosocial, spiritual, or biomedical problems. So in Australia, disability is understood as a multi-dimensional concept. So it relates to impairment in the body structure or function, limitation in activities, which is one of the most obvious things that is more visible. You know, are you able to do the activities that you normally do? And also restriction of your ability to participate in your environment. So whether that's at home, whether that's your social life, whether that's your working life, you know, if you're restricted or impaired in terms of, you know, doing those things that you normally do, then that's part of disability. So disability can occur without chronic disease, so intellectual disability or developmental disability. But, you know, in this context, we're looking at disability in terms of associated with chronic illness. So rehabilitation, so this refers in a holistic sense. You know, rehab, you'll often hear people talk about rehab, but in a very broad sense, we're talking about someone's experience, their journey, their path that they take towards in terms of experiencing disability and hopefully promoting quality of life and promoting ability. So there's a whole variety of interventions that can take place for rehab in the context of chronic illness. So let's say for stroke example, you know, what's the goal of stroke rehab is that we want an individual to relearn any skills that have been lost when that stroke has affected part of their brain. So doing early rehab for stroke, people who've had stroke, can really help people to regain their independence and improve quality of life. So that's the interface between rehabilitation and chronic illness in this example of stroke. So rehab, you know, it should be person-centred, it should be mutually agreed. And when we talk about goals, we should always try to make goals achievable. Otherwise, it's going to be hard to make progress or build momentum in terms of progressing towards rehabilitation to the former ability that, you know, abilities pre-illness. So, yeah, there's actually in the literature, there's quite a very strong opinion piece that chronic illness, disability and rehabilitation, these things that we've just been talking about, these once, you know, they actually weren't covered in nursing education before. But you can see that with the changing priorities, I suppose, in the health system is that, you know, it's really important that we do cover these things. So let's look broadly at the scope of chronic illness and why there's a need for prevention. So there are several chronic conditions in particular that pose a significant burden. So in terms of morbidity and mortality, so we're talking about how many people are experiencing the illness, how many people are dying from the illness, and the healthcare costs that are associated with treating or managing that illness. And these chronic conditions are actually receptive to preventative measures. So that's why governments and health systems are saying, hey, these things are causing such a big problem and yet we can actually do something about it. So coronary heart disease and heart failure, stroke, type 1 and type 2 diabetes mellitus, and gestational diabetes, kidney failure, so renal disease, and respiratory disorders. So I mentioned COPD before. Asthma is also a huge problem. Sleep disorders relating to breathing, so sleep apnea, lung cancer and cystic fibrosis. So chronic mental illness like depression, anxiety, schizophrenia, these are things that people can live with throughout a whole lifetime. So cancer is a growing problem and, you know, wasn't always recognised as a chronic illness, but increasingly so. And, you know, our second assessment for this unit will focus on a cancer case study. So musculoskeletal conditions, so arthritis, osteoporosis we've mentioned, and these all have chapters in your textbook. Chronic pain is a big problem as well. So this is cited in the Queensland Health Chronic Disease Strategy. Now, so for probably the past 12 years, I think since 2005 in Australia, we had a National Chronic Disease Strategy, the NCDS. Now, so this identified 4 key strategic areas. So prevention across the continuum, being the lifespan, or continuum of care as well. And we'll really get into prevention next week, actually. Early detection and early treatment. And then number 3, integration and continuity of prevention and care. And 4, self-management. So we're really going to be covering all of this. Prevention across the continuum in a very big way, and self-management in a very big way. So you can come back to those and just remember and try and see where these fit into what we're going to cover, but I'm sure that will be self-evident. Now, so the National Chronic Disease Strategy did identify national priority health areas. So initially there were 5: asthma, cancer, cardiovascular disease, diabetes, and musculoskeletal conditions. These were actually expanded to 9 national health priority areas. And just as of mid last year, so your textbook will actually refer, I'm going to go back, your textbook will refer predominantly to the 2005 National Chronic Disease Strategy, because the framework, the strategic framework, was actually still in development when that book was published last year. So you can, this is in the reference list here, you can find this National Strategic Framework for Chronic Conditions. And that was developed by, so COAG Health Council, which is it's the Council of Australian Governments, COAG. So, you know, in each state and territory we have local government departments, but then on a federal level, they all need to get together and talk about what are national priorities, not just what's happening in Queensland, for example. So this is an outcome of that national dialogue that's been happening, you know, and it's been 12 years since the last kind of equivalent of this. So what is the overall vision? You know, what does this document, this policy document actually do? It's got strategies that, in effect, it's on a national level, they're trying to achieve this vision. So all of the governments around Australia want to see all Australians live healthier lives through effective prevention and management of chronic conditions. So, you know, we've got 2, if you were to kind of break that apart, there's two real components which contribute to the outcome. So effective prevention plus effective management of chronic conditions will achieve healthier lives for all Australians. So that's ultimately what is trying to be achieved on a national level. So looking on a local level, so you can find this document as well on the internet. So My Health, Queensland's Future, Advancing Health 2026. So this is the local state level equivalent here in Queensland. So published in 2016. So looking at a 10-year vision there. Let's have a look at a bit more detail. So in a snapshot, so by 2026, looking at a projected population of 6 million here in the state of Queensland. We see a breakdown of population health there in terms of Aboriginal and Torres Strait Islander proportion there, that's increasing. We're looking at rurality or locations, so remote areas versus metropolitan. Also looking at health outcomes for people with disability as well. So that's looking at population. Now, looking at workforce as well, because we always talk about an aging population, but, you know, our workforce is aging as well. So, um, yeah, it's something we need to bear in mind. Let's look at chronic disease. So in the bottom left-hand corner here. So chronic disease is a primary cause of death in Queensland, with you know, increasing impact. So the majority of chronic disease deaths are due to cardiovascular disease and cancer. So they're the two big ones, at least in Queensland as well. Now here in Queensland, interesting, we have the highest rate of adult obesity in the country. And the incidence of diabetes is projected to double over the next 10 years from 2016 to 2026. So we can see that there are big challenges coming, and, you know, we're starting to try and prepare ourselves and work out how best to manage and deal with those. And part of that is prevention. So projection here that 3 million Queenslanders will be overweight or obese by 2020, so in 2 years. And it's projected that two-thirds of the burden of type 2 diabetes is due to excess weight and physical inactivity, so lack of exercise. So look, interestingly, survival of acute coronary heart disease is increasing. So that's another thing we're going to talk about. So cardiovascular disease and cancer, we have more people surviving. More people surviving stroke, more people surviving cancer. But survivorship is something that is also part of chronic illness and part of self-management, because, you know, recurrence of stroke, recurrence of cancer is certainly something that happens. Look, so life expectancy again, so this is another population kind of health factor. So as I mentioned earlier, we're living longer, but we're living longer with more disease and more chronic illness. Now we're going to touch on closing the gap in a little bit. So there's just an interesting fact there about rates of risky drinking, 16% higher in Queensland than in other states around the country. So looking at healthcare expenditure, so the budget, so just under 15 billion. So Queensland, in Queensland, the health department has the largest budget of any other department, in any other government department. So, you know, the Queensland government spends more on healthcare than it does on anything else. You can see here that proportion, that percentage. That the actual green is Queensland government funding. The light blue is the Commonwealth government funding. That's the breakdown for the healthcare expenditure. We've actually just covered that. That's just in a little bit more zoomed in. So look, here's an example. So Sunshine Coast Hospital and Health Service. So the incidence of chronic illness and disease is increasing, and that's increasing healthcare demand. So approximately half of all admissions to facilities in Sunshine Coast is for chronic disease. By 2026, if this doesn't change, if we don't change what's happening, it's estimated that there'll be at least 116% rise in patient admissions. So there's a lot that needs to be done in terms of prevention and better managing chronic illness. So the kicker for all of this is that a very large proportion of these admissions are actually avoidable. So that's where we're trying to be a bit smarter in the way we work, and we'll see that in the next lectures over the next few weeks. So that's a really broad look at chronic illness in Australia in our context. We're going to now touch on population health, and then we'll get into health promotion after that. I'll go a little bit, I'll speed up a little bit just because I know we lost some time at the beginning, but you can come back and watch this recording. So look, what do we mean by population health? Some of you may have done some studies in public health previously, or you might be doing it now. So this may be not new, or it may be a refresher to you, but for some other people, this might be new. So when we talk about population health, we're focusing on the collective health or the collective illness in populations or subgroups within a population. And this is rather than the health or illness of an individual. So instead of thinking about, as a clinician, if you've got your patient load and you think about, okay, well, Jason's one of my patients, that's the individual level. If you were to kind of expand, you would go, okay, what's my patient load? How many patients have I got in my care on this shift? That might be 6 or 8. So that's just beginning. And if you keep going, broadening out, so instead of the individual, we could go right to the extreme and go, okay, what is the health and illness of the Australian population? And you could look at statistics for all of that. Within that Australian population, you could look at, okay, what is the health and illness in Australian and Torres Strait Islander people? So that's like a sub group within the Australian population. Women's health, men's health, older people's health. So these are subpopulations or subgroups within the broader population. And then going further, child and adolescent health, maternal and infant health. So these are really obvious examples of taking a population health perspective. So for those of you who accessed the Grey Nomads article, Grey Nomads, so that population would be older people who are actually mobile and travelling as their lifestyle choice. So men's health. I think I mentioned in the orientation lecture that I participated in Movember last year with my dad because he had prostate cancer. So, Movember are great in terms of highlighting key issues in men's health. And so the statistics here, I think this is coming out of Canada though, that men make up 50% of the workforce, but 94% of all workforce fatalities are represented by males. Cardiovascular disease, suicide and motor vehicle accidents are the top 3 reasons for reduced lifespan in men. Men are more likely to die from heart disease at earlier age. Liver disease. There's one of the key issues about men's health is that often males are reluctant to seek help, or they're kind of, she'll be right, I don't need to worry about that, I'm fine. So interesting little slogan here that having a Y chromosome is not an excuse for unhealthy lifestyle choices. Women's health. So actually this month is, February is Ovarian Cancer Awareness Month. So if you went to the Ovarian Cancer Australia website, or if you went on Twitter and used that hashtag, OCAM2018, this is an example of a health promotion activity where this organisation, Ovarian Cancer Australia, have claimed this month as a target month for raising awareness of ovarian cancer. And so raising awareness is just one small thing that can have a big impact on influencing women to think about, oh, I haven't thought about ovarian cancer. What are the risk factors for that? What are the protective factors for that? What could I be doing to minimise the risk of me getting ovarian cancer? So this is part of their campaign. So they have these gifts available on their website. So one of their key priorities is actually informing women about the risks. For people who haven't thought about it, these are risk factors for ovarian cancer. So again, it's part of education. The message is, take action, know the risks. And then another part of their campaign is knowing the symptoms. So knowing the risks, but then also knowing the symptoms. Have you been feeling pelvic or abdominal pain? Have you had abdominal bloating? If you have, then it's time for action. Go and get a checkup. So this is part of health promotion. It's just one part. So February, it's the month of awareness for ovarian cancer. And so this is looking at a population health for women. So what interventions can we think about? Can we see that have been, I guess, designed and implemented for population health? So if you think about it on a very broad level, we take a lot of these things for granted. So Medicare, the provision of free, universal, publicly funded healthcare, that is a key population health intervention. If you go to the US, you wouldn't have that same thing. Access to clean drinking water supply and sanitary waste disposal, that is a population health intervention, you know, thinking of the population of the whole country, then even on local levels in terms of state and territory council level. If we didn't have access to clean drinking water or sanitary waste disposal, our incidence of infectious disease would be, you know, terrible. And it used to be like that until we prioritised and said, hey, we need access to clean drinking water and we need sanitary waste disposal. Legislation for road safety, so mandatory wearing seatbelts, speed limits, regulations about, you know, drinking under the influence of alcohol, exposure to secondary tobacco smoke. All of these things, once upon a time, you didn't need, there weren't even seatbelts designed in cars. You could drive as fast as you want. You could blow smoke in the face of children. But, you know, looking at population health and thinking, hey, we need to prevent accidents with major road trauma. We need to prevent people drinking when they're highly intoxicated. We need to prevent young children from getting lung cancer from being exposed to tobacco smoke they don't even have a choice about. Regulation of water quality, safety in public swimming pools, food safety standards, access to antibiotic drugs like penicillin, I've touched on before. And really, we can see the impact of population health interventions in terms of the fact that we are living a lot longer because of all of these things that we've actually implemented. So you can kind of have micro, meso and macro levels of population health. If you start from the individual, like I said, if just Jason is your patient, you know, that's the individual. But then when you start to think collectively, that's what we're looking at in terms of population health. And look, you can see here, this is from the Australian Bureau of Statistics in 2013. So looking at Australian life expectancy at birth by gender. And so since 1890 there, you can see a steady rise, a little bit of a dip here for males, but steady rise in terms of life expectancy. And so that's really just a graphic showing the impact or the influence of all of these population health kind of measures that have been put in place, which are having an effect. You know, we're living longer, we're not dying quite as young as we used to. So just digging deeper into the Australian context. So it is about health and illness. And obviously we're focusing on improving the health and well-being of Australians through targeting priority areas that are identified. So these can be, you know, between social groups. So we're going to look at social determinants of health. And as I mentioned, population subgroups. So priority population groups, priority age groups, and national health priority areas. These are three key or priority population groups that have been identified here in Australia. So starting with priority population groups, so Indigenous health, it's a huge priority. People in rural and remote areas, the health of people living in rural and remote areas is a population health, it's a population group. And think about, you know, they won't have the same access to facilities as we do. So that's just a really key kind of factor there. economically disadvantaged people, veterans' health, health of prisoners, and people born overseas. So these are designated priority population groups here in Australia. So closing the gap, it's been 10 years since this closing the gap strategy was kind of launched, and this report came out recently and kind of identified that we haven't made as much progress as we would like to have. So the life expectancy gap between Indigenous and non-Indigenous Australians remains really high, despite the last 10 years of this closing the gap strategy. So looking at males, it's nearly 11 years difference between the general population and an Aboriginal or Torres Strait Islander person. So that's a huge, discrepancy in terms of life. 11 years of life, living life lost compared between, females, slightly lower, but still just under 11 years difference in life expectancy. So there are a lot of factors. It's not straightforward. It's very complex. But I think as a nation, the consensus is that we can make more progress in that area, and that we need to. So that's another population health perspective that we, and there are particular chronic illnesses, particular chronic disease that are overrepresented in the Indigenous population. So priority age groups. Mothers and babies, so we mentioned maternal and infant, child and infant health, children, young people and older people. So that's pretty straightforward actually in terms of age groups, and adults just kind of fit, go across the spectrum there. But pediatrics and aged care, very challenging areas, and also with maternal and child health, really important time in the lifespan. Yeah. Now, so I mentioned that there were more earlier. I showed 5 when there were only 4 or 5 national health priority areas. So that has expanded to 9. So cancer control, number 1, cardiovascular health, injury prevention and control, which it's not a large focus for us here, but we can see through population health that, preventing injuries through wearing seat belts, things like that, it is an important part of, it's an important health priority, because injury does create chronic illness and disability, so acquired brain injury, for example. So mental health, growing priority, diabetes also, asthma, arthritis and musculoskeletal conditions, obesity and dementia. So look, this really underpins the rationale for this unit, is that nationally we understand that it's a priority that we need to, that strategies need to be holistic, and they need to encompass the continuum of care, from prevention through to treatment and management. So those 3 words that I've highlighted, they're a big part of what we're focusing on, largely prevention and management, actually. So, I mean, this is old data, but sometimes that happens with the ABS, that it takes a long time to get large data sets across the whole population and get them analysed. But in 1996, those national health priority areas accounted for 70% of the total burden of disease and injury in the country. So that's 81% of the years of life lost, and nearly 60% of years lost due to disability. And that's just a graphic of that. So you can see cardiovascular disease and cancer, the top 2 from that data. And that hasn't changed, actually. Dementia, though, is missing from that picture, and that's a growing problem. So in summary, chronic disease, we said at the start, it's a growing problem, and we need to think about different ways we can be clever in terms of prevention and management, and that takes partnership. So in Australia, 1 in 4 people are affected by chronic disease, and many of those aged 60 or above are estimated to have more than 2 chronic conditions. I think we'll actually find that's increased, that 1 in 4. We'll touch on that next week. I think that's actually increased to nearly 50%. So what's the priority? Prevention and management. So interventions to prevent and manage chronic illness, that's where it's at. It's really the priority. So really, it isn't a surprise. It shouldn't be a surprise. So moving on to health promotion now. Whoa, that was a little bit too quick. Health promotion, so what is it? Again, some of you may be familiar with health promotion. If you could please stop doing that, that would be great. I don't know if you guys can see that on the screen, but it's not very respectful. Because really, yeah. Thanks, Andy. Alrighty, so health promotion. For some of you, you may be familiar with health promotion through public health studies. For others, it may be a refresher. For some of you, it might be new, but it's a key part of our study in this unit. And it's a core, no worries. No, thanks, Andy. Okay, yeah, look, health promotion, as I mentioned in the orientation lecture, that our need to be competent and understand health promotion, it is explicit. It is so clear in our practice standards. We can't register, you can't become an RN unless you've got this bread and butter down, unless you can understand and actually practice health promotion. So it is an important part of our work as nurses. Look, here's an example that's, I already touched on the ovarian cancer kind of awareness promotion, which is just one aspect of health promotion and one aspect of education. In your workbooks, I put a link there to this Queensland Health resource. Unfortunately, I've just, there we go. Been testing it recently, and it used to work beautifully, and all of a sudden there's a glitch in it. If you want to try it, feel free, but I have spoken with Queensland Health, and they're looking to fix it as soon as they can. But it takes you through all these steps and asks you all these questions, and it's really interactive. And then when it says, okay, it's time to get your results, it kind of freezes. So that's an example of technology that it can be an epic fail or it can be awesome, but it's a matter of managing that and rolling with it, I suppose. Yeah, it can really help or hinder at times, technology. But anyway, so this health and fitness age calculator, just as an example of a health promotion tool, what it does is it assesses these domains. It assesses your level of sedentary behaviour. It assesses your intake of fruit and vegetables. It assesses your intake of sugary drinks, and it also looks at portion sizes. So, are you eating more than you should, maybe? And really, what it does at the end, it's the reason why it's kind of cool, is that it asks your age as well. And so, if you say, "Well, I'm 22." And here's all of my answers to the questions. What it does at the end is it says, well, according to our calculations, your health and fitness age is X. And so let's say you are actually 22. If your lifestyle, if you're really sedentary and don't have any physical activity, if you don't have a very good fruit and vegetable intake, if you have a high sugary drink intake, and if you eat a lot, more than you need, it may say that, well, actually, we know that you're 22, but your health and fitness age puts you at 45. According to the data you've given, if you keep going the way you are, your lifespan is actually going to be shortened by the difference between what your actual age is, 22, and what your health and fitness age is as it's been calculated. So that can be a bit of a wake-up call. If you're 22 and you look at your current lifestyle and think, wow, this calculator is actually saying that my body, that if I keep going like this, then I'm actually going to shorten my life by X number of years. And it can be a wake-up call to say, hey, okay, I need to start changing some things. And it actually gives you step by step and says, this is what you can do to help shorten that gap, to minimize that gap. You can make sure that you are more active, get at least this amount of physical activity each day. Make sure you have at least this amount of fruit and vegetable intake. So it's a really good tool when it works. And look, there's a link to that in your workbook, but in the workshops, we're going to use a different tool since this one isn't working. And that'll actually calculate your risk for type 2 diabetes. Okay, so look, if we're going to talk about health promotion and understand more about what health promotion is, we need to first start by clarifying what do we mean by health. So the go-to definition of health has always been the World Health Organization, and it's an important definition because it says that health isn't just the absence of disease. It's actually a state of physical, mental, and social well-being. So just because I'm not diagnosed with any clinical disease, it doesn't mean that I'm necessarily really healthy. I could be, my lifestyle behaviors could be terrible. And, my physical, mental, social well-being could be not so great. And I could go like that for several years until I actually then have symptoms of a disease that can be diagnosed. So it is really important that we think of that broad and more holistic sense of what do we mean by health. Just because I don't have a diagnosis of cancer, schizophrenia, osteoporosis, arthritis, doesn't necessarily mean that I can put my hand on my heart and say, well, I'm really healthy. Because, of all of those things that I've just said, physical, mental, and social well-being, kind of like nuts and bolts that contribute to the totality of health. So yeah, that's what we mean by health, and we need to just kind of remember that. Because we can optimize our social well-being, we can optimize our physical well-being and mental well-being. That's the other important thing about this definition. It's not just, okay, are you disease-free? Good, you're healthy. It can be, hey, are you physically active? Are you optimizing your well-being, which can really put you into a positive rather than I'm just at neutral, zero, I don't have disease. Yeah. And a lot of what we want to do in health promotion is promote all of those healthy behaviours so we can be in the most optimal well-being across those domains, and that will minimise the risk of disease. Okay, so more of a textbook kind of understanding of health promotion. So defined health promotion is the process of enabling people to increase control over and to improve their health. So it's worth reading that again. So promoting health is about enabling people to increase their control over their health and to improve their health. So there's an aspect of empowerment there, which is important, and we'll touch on that a bit more as we go. But ultimately, it's about helping people improve their health, but also about increasing control over health. And if people have to manage chronic illness, self-management, then they need support in doing that, and we're gonna focus on that. So the Ottawa Charter for Health Promotion, so 1986, This is a key landmark document for health promotion. It was the first international consensus about, hey, health promotion is a priority and this is what it is. This is how we can start to do it. So firstly, by building healthy public policy. So that on a government level, that informs things like laws, regulations, which can, I guess, influence public health. Number two, creating supportive environments. So recognising that individuals within environments it can be very difficult to promote your own health if the environment that you're in isn't conducive to that. So whether that's a workplace environment, whether that's a community environment, the Ottawa Charter for Health Promotion recognises that environments play a big role. Strengthening community action. So this is about recognising that health isn't just the business of healthcare professionals. Promoting health and preventing illness is part of our community as well. Looking at an individual level, developing personal skills. So this is about self-management. So this is about someone living with diabetes being able to monitor their own blood sugar level. Nurses, healthcare professionals aren't always going to be around to do things for people, and we don't really want them to be dependent on us, do we, ultimately? So personal skills is part of where we will provide education, help people build skills so they can go home and manage their chronic illness without having to rely on healthcare professionals. And then lastly, reorienting healthcare services. So this is important. It's about shifting the focus of healthcare from treatment towards prevention. So, hospitals, we're very good at, we're geared towards fixing problems, treating acute illness. But what we need to be better at is, in terms of out in the community, preventing more of that illness and promoting more health and well-being. So then we don't have EDs full of people all the time. For those who have an interest in mental health, Australia is famous for the Melbourne Charter. You may or may not have heard of it, but this is a build on from the Ottawa Health Charter, which really situates mental health in terms of, hey, we need to promote mental health specifically. Now, this little clip is really handy. It's only a short one. It helps to really understand what we're talking about in terms of prevention. So instead of treating or fixing the problems that land at ED, we need to be better at promoting health and well-being so less people need to come to ED. This is in the context of chronic illness. Now let's actually... Now, actually, I'm not sure if this clip's going to work for you guys because... Okay, let's do that. Okay. Okay, so I hope that helped some of you just to conceptualize. So really the take home from that is that investing upstream in prevention is much more effective than having to focus all of your energy and time in intervention downstream. So, you know, it's a really classic analogy, upstream versus downstream, is that if you think about we as clinicians, we as clinicians spend a lot of our time downstream, catching the people who are drowning down the river. Whereas, you know, health promotion and in particular prevention really forces us to think further upstream and think, hang on, we're dealing with a problem, but what's causing the problem? And can we start to actually address that to prevent the problem from happening in the first place? And like it said, you will still get, the problem won't disappear completely. You will still have people, you know, downstream, but it's not at a crisis point. So, and that there's less, so it's more manageable. There's another clip here which we'll actually look at it because it's looking at social determinants of health. So I will just. Okay, so we can see from that, I mean, it's without wanting to be simplistic, it can appear simplistic, but we know it's not that way. But really the message there is that when we're looking at health and illness in individuals or populations, we really need to understand the social context. So things like education, things like employment, things like financial, socioeconomic status, they all impact on choices that we make, on decisions that we make, on behaviours that we engage in. And they ultimately impact on our health and the illness that we experience. So social determinants of health is a really important factor that we need to be aware of and to really consider when we're practicing as nurses in our clinical care. Because if we're doing education, if we're helping develop care plans and things like that, we need to, you can't just look at a disease. You need to look at the experience of that illness in the context of someone's life. Everyone has a story and everyone has their own way of living in the world, and what works for Jane may not work for Peter or Tom, depending on their circumstances. So you may need to approach things differently. Look, there are some examples of really early health promotion activities. So I'm not going to play this one. These are really old quality, but this is a slip, slop, slap. Back in the 80s, this was when, really we were starting to recognise and prioritise doing something about preventing people from getting skin cancer. So it was slip on some sunscreen, slop on a hat, and slip, slop, slap. It was, I can't remember the other one, but it was about wearing sunscreen, putting on shades and putting on a hat. Yeah, slip, slop, slap. So some of you might remember that. Here was another one, similar era. This was about obesity, and it was about actually having a more physical and active lifestyle. Yeah, again, I won't play that. The quality is not so great, but some of you that might bring back memories for some of you. I think that was Norm, actually. So look, here's some more modern examples. This was, I think, circa 2012, 2013. So again, looking at obesity, actually. So encouraging people to just make small changes. It was called Swap It, Don't Stop It. So really encouraging people to replace unhealthy behaviours with healthy alternatives. And really this was about trying to say, well, it recognised that just telling someone to stop doing something wasn't so effective, and it wasn't likely that people would just stop doing something. So the emphasis was, rather than giving something up altogether, it was about looking at more healthier alternatives. Again, swap it, don't stop it. So swap a feed for a lead, go take the dog for a walk. So you can see there, it's about reducing your risk of chronic disease. And, these kind of campaigns are on advertisements on billboards, on trains, on buses, and on, TV commercials and websites. We will play this example. This is a more modern, I think this was actually 2008. So this was an obesity campaign called Measure Up. And let's have a look at that one.
You know how it is. You settle down, put on a few kilos, but I'm not worried.
1 in 2 Australian adults is overweight.
Then you have kids. Life gets busier. You let yourself go a bit. I'm not worried.
Unhealthy eating and drinking and not enough physical activity can seriously affect your health.
Tip your dad.
For most people, waistlines of over 94 centimetres for men and 80 centimetres for women increase the risk of some cancers, heart disease and type 2 diabetes.
But when I first realised it was affecting my health, well, yeah, I got worried.
The more you gain, the more you have to lose. To find out how you measure up, go to australia.gov.au/measureup. Authorised by the Australian Government, Canberra.
So there you go. That was the Measure Up campaign. I'm just going to switch back. Yeah.
In an experiment in a restaurant, people were randomly seated near...
We don't need random seating. Okay. Let's move right along. So yeah, so these are some examples of more contemporary health promotion campaigns. And I'd really, I mean, depending on the government of the day and what their priorities are, you know, priorities shift either toward or away from prevention and health promotion. But, you know, I'd invite you to just take notice and just see what you notice around you. In terms of what's on buses, what's on trains, what's on billboards, what do you see on the TV commercials, and just try and just spot them and just recognise anything that's actually a health promotion activity. Now, so one thing about health promotion is it can be quite difficult to evaluate and generate evidence for. And I know many of you completed NSB 203 inquiry in clinical practice last semester. So if you did that, build on whatever you took out of that in terms of, hey, where's the evidence? Does this actually do anything? Does it work? Hold on to that, apply that, be critical, because, you know, one area where health promotion struggles sometimes and can really benefit from improving is in terms of generating an evidence base and saying, hey, we know that this works and this is how it works and this is how effective it is. So, you know, and whether it's technology, whether it's any health promotion thing that we're talking about in this unit, don't be shy, don't be afraid to say, hey, you know, it sounds good, but is there evidence for that? Or, you know, if you find that there's a health technology, a health resource, electronic resource that actually is pretty bad and it's not very good at all, that's fine. Tell us, you know, when this unit isn't at all about saying, hey, all technology is awesome and you know, we're not expecting you to find that it's all rosy. You know, the quality really varies and technology is not always simple to use. So, you know, be critical, be balanced, you know, like there's usually some benefits, there's usually some limitations. So that's absolutely fine. So here this was an Australian publication. I think it's actually, so again, this is about the Measure Up campaign. And the campaign was really aimed at reducing lifestyle-related chronic disease risk, so the risk of. Oh, I'm going to go back there. What you often find in things like this is that, for example, this study, they will find that, yes, okay, this intervention, this advertising campaign increased awareness of X. You know, it raised the awareness in the community by this much. So you can see here, 38% and 89% awareness from pre to post campaign. So from 38 up to 89. But what it didn't actually achieve, so it was successful in that way, but it actually didn't, it didn't influence anyone in changing their behaviour. So look, maybe that's a good start, but it's important to know what's working and what's not, you know. So this particular campaign was successful in raising awareness, which is beneficial, but maybe a more targeted intervention is actually needed to help people get from being aware of something to actually going and changing their behaviour. You know, it's one thing to know that, well, yeah, I know I'm at high risk of getting bowel cancer. I know it, I'm aware of it now. But, you know, am I actually going to change anything? That's the next important step. So the Shanghai Declaration is actually, so this is only 2016. This was a more recent, everyone always talks about the Ottawa Charter, which is 86, it's 30 years old. But this was like an update, the Shanghai Declaration. Obviously, it was in China. So really, this was about highlighting the need for people to be able to the need for people to be able to control their own health, to be in a position to make healthy lifestyle choices. So this is part of health promotion, and it's part of our role in providing education, but empowering and helping people to actually be in control, make healthy decisions and lifestyle choices. It also highlighted the role of governance and health literacy. So health literacy is something we're also going to focus on because, what do people need to be able to control their own health? They need health literacy. We as health professionals generally have really good health literacy because we study health and we study illness. But, most people don't do that. So part of our education is really looking to build health literacy, because when people are health literate, then they're better able to control their own health. They're better able to prevent illness. So we'll come back to that health literacy again and again. Now this is another little clip, but you've got the hyperlink there. You can go and watch that from the lecture notes if you like. But I think for now it's something that's kind of nice to watch, but it's not that essential at this point in time, considering that we lost a little bit of time at the start. Now, so you can see there #ChooseHealth. So I'm not just a Twitter freak, it's the World Health Organization as well. Usually there's a hashtag for most things these days. For conferences, there's hashtags. You've even got one there for this unit down the bottom of the lecture notes. Look, so this is an important piece of health promotion material. So it came out of the Shanghai Global Conference on Health Promotion. And really, they're trying to move on from the Ottawa Charter and say what's really important at this point in time. And you can see there that number 3, health literacy. I've just been speaking about that. And, governance kind of applies to government policy and things like that, regulatory frameworks. Healthy cities is about community. It's about a whole of community approach to preventing illness and optimising health and well-being. Health literacy, that's, I think, bread and butter for us. That's core foundational priority for us. So in this unit, like I mentioned, if an individual is living with chronic illness and therefore needs to self-manage that chronic illness, they need support. And part of our role is to provide self-management support. In doing that, we provide education because, like I said, we study health and illness. The rest of the community generally don't. So we need to share our expertise, share our knowledge, provide people with the tools and the skills, help them build the skills they need to be their own expert 24/7 when they're at home, because they don't want to live their life in a hospital or at a GP. So health literacy, that's, it's a key outcome of what we want to achieve by providing education. This has been researched, the better health literate people are, the more healthy decisions and choices they make, and that impacts on their health status. And conversely, when there's a lack of health literacy, we see that health status declines in correlation with low health literacy. So really, health literacy is about increasing knowledge and social skills to help people make the healthiest choices and decisions, not only for themselves, but also their families as well. Again, coming out of that same campaign, the Shanghai Global Conference is this other resource. So #ChooseHealth again, but 12 tips to be healthy. So this is very broad, from eating a healthy diet, being physically active, minimise tobacco use, minimise harmful consumption of alcohol, manage stress, all of these things. So this is a resource that World Health put out in terms of these are 12 tips to live a healthier lifestyle. So look, local example here. Thanks, Andy. Yeah. So slip on a shirt, slop on sunscreen, and slap on a hat. Love it. Thanks. Yep. I was scratching my head trying to remember. I can still hear the TV ads. Slip, slop, slap. Okay. So look, here's a local example of, this is an example where, hey, health promotion isn't something out there that when you're an RN you will do one day, maybe, perhaps, when the right patient comes along. It's something that you can do with your family. You can, helping people build their knowledge and their literacy around health is something you can do at any time, whether you're a registered health professional or a registered nursing student or not, whether you're a paramedic. And look, so I've got 2 young boys, and they go to one of the local primary schools. And when we moved up here last year, I was really impressed that they had this teddy bear hospital clinic. So these were UQ medical students who decided that, they wanted to get engaged and involved in health promotion early on. So they arranged to go and visit local primary schools, and they visit, prep school kids, students in prep. And they start, actually laying the foundation for, what are some healthy things you can do, from being physically active and making sure they've always got a hat on and sunscreen and drinking lots of water, to making sure they've, brushing their teeth and things like that. But ultimately, underneath all of that was the importance of having a positive relationship with health professionals. So I think it's quite skillful, actually, because instead of kids growing up thinking, oh, I don't want to go to the doctor, or I don't want to go to the dentist, that's scary. Mum and dad only go there when there's something wrong. So these medical students thought, hey, let's build a positive relationship with kids right from a young age. We'll call it a teddy bear hospital or clinic or something. And so they're trying to form positive relationships so kids can, relate to a doctor as, oh, yeah, that was fun. We saw those doctors who came and spoke to us at school, and, it wasn't so scary. So look, that's just one example of, health professional students getting involved early on and, participating in health promotion, really. And that's actually a population perspective when you think of it. They're looking at young school children and really targeting that subgroup within the population. Look, here's just one. The federal government here used to have a health promotion website, and it's been decommissioned, unfortunately, between last year and now. So that was on this slide last year, but it's gone. We still have the World Health Organization. You can check out that link, and they have a whole lot of resources on health promotion on the World Health Organization website, including those banners that I just showed before about the 3 pillars of health promotion and 12 tips for a healthy life. So look, in summary, we oriented ourselves to the context of chronic illness in Australia and disability, mainly chronic illness. We looked briefly at population health. What are the principles of population health? What do we mean by population health? And we broke down through all those different layers, from the national population right down to individual. And then finally, we looked at health promotion. What is it? What do we mean by health promotion? What are some examples of health promotion activities or interventions? Some of those are advertising campaigns. Some of those are, more than advertising. It's about actually engaging with people. And look, that's really a broad foundation for us to build on next week when we're going to look at risk factors for chronic illness, which are really important to understand. There are different risk factors for different chronic conditions, but there is also some kind of overlap in between. We're going to look at protective factors as well. So what are factors that actually are protective for us in terms of I can minimise my risk of getting bowel cancer if I do X, Y, Z, you know, by looking specifically at protective factors. And then also next week, we're going to look at specific or key health promotion strategies. So this is really important because when you go to do assessment 1 and then when you go to do your final assessment, I want you to have it clear in your mind what we mean by health promotion strategies and what are the key ones, what are the key strategies, because there are some in particular which we will emphasise, which I think is important for you to understand rather than just saying, oh, we just provide education, because that's not quite enough to say that, you know, we just provide education. There's actually a more strategic thinking behind what we do. So, you know, there are health promotion activities or things we do, but the strategy is kind of like the informing principle as to why are we going to do this, because strategically we want to do X, we want to prevent something or we want to promote something. So yeah, that's the summary of today's lecture, and I just really want to say thank you again for everyone for bearing with me through the beginning of this lecture. I really appreciate your understanding and your patience. So we do have some time for some questions. Let's see. Thanks, Andy. Yeah, so if you've got some questions, please feel free to type those in now, and I will do my best to answer them on the spot. Or otherwise, yeah, health promotion as nurses, yeah. So if there aren't any questions, that's the end of the content that I wanted to share with you in terms of presenting today. But please do feel free to send me an email, or what I would really encourage is to make use of your Padlet discussion forums, because for multiple reasons, if you're unsure about something or wanting to know the answer to a question, then it's likely that other people as well might be wondering the same thing. So by putting it out there on the discussion forum, you're share, you know, when we put the answer there, it's there for everyone. Okay, so I'm just letting everyone know for assessment, questions about assessment, please use your discussion forum. You can be anonymous. You don't have to put your name on your Padlet discussion forums. So, you know, you don't have to worry about, you know, I don't want to sound like, or I don't want anyone to know that I'm asking this question. It's anonymous. You can put your name or you don't have to. So, it's a kind of safe space where you can ask questions and no one knows that it was you who asked it unless you actually put your name there. So yeah. Yeah. Any other questions before I kind of close the meeting? Okay, great. Okay, so we've got a question. So as a hospital nurse, how will you engage with health promotion strategies? Okay, great question. Thank you. So look, that's a really interesting question. So when you register here in Australia, as a registered nurse, there's no distinction between being a hospital nurse or a other kind of nurse. Just like there's no actual distinction between mental health nurses and other nurses now, there used to be a separate training and a separate registration for what used to be called psychiatric, registered psychiatric nurses. As of 2010, all nurses are registered. We're all registered nurses. And so that goes as, I guess what I'm getting at is that being able to promote health and well-being. So health promotion is part of our business, whether we're working in a hospital or not. It's a really important, it's a great question, because sometimes people think, well, I work in a hospital, so I don't do that. So health promotion is something that we can do just by talking. So health promotion is done in hospitals every day, all the time. Actually, if you look up the World Health Organization, there's actually a policy framework called Healthy Hospitals. And what that's about is actually recognizing that hospitals traditionally have been focused on just treating, fixing problems, treating people once they're already sick. And, you know, this concept of having healthy hospitals is about saying, hey, we need to more explicitly embed health promotion into our hospitals. We need to think more about prevention and really embody health promotion in hospitals. But I guess my answer to your question is that, you know, if you look at what health promotion means, look at the definition of it. So it's about helping empower people. It's about helping improve people's control over and ability to improve their health. So we can do that through providing information, whether it's resources. We can do that through talking to people, asking what. So, you know, if one of the key, I guess we're going to get into this more deeply next week when we talk about key strategies for health promotion. And I will include a case study that is relevant to the hospital. Thank you for asking that. So I will make sure that we have some concrete examples of, okay, you're a nurse on this ward, and here's an example of how you can engage in health promotion in the hospital in this clinical scenario. But yeah, I guess we're looking really broadly at the moment, and we'll go deeper and more specific. So for now, you know, my answer would be that just through talking and providing information, resources, which is partially why we're going to actually look at resources for assessment 1. And in assessment 2, this will be in a lot more depth about, okay, you're a cancer nurse working in a hospital, and your patient is finishing his chemo and is getting ready for discharge. So how can you start to do some health promotion work? But yeah, so the education that we provide, it's ultimately aimed at building health literacy. So that, you know, building health literacy is part of health promotion. So by building health literacy, we're helping firstly to understand where someone's at, whether they have a good understanding of the illness or they may not. And what that tells us is, okay, if they don't have a good understanding, we need to help them build that understanding, whether that's through talking with them, providing information, and then talking to them some more. And then, you know, helping them build the capacity or the skills to self-manage, to check their own sugar levels, to self-administer insulin. And, you know, we might demonstrate, show them how to do it, then we might ask them to do it themselves while we watch. Yeah, so, oh, thanks. Yeah, so thanks, Beth. So the O-Week lecture has finally come up on Blackboard. Thank you. So there's just a question about Padlet. So what you have is you have a discussion forum for each of your workshop groups. So for each workshop, there's just a tad under 50 people in each workshop. So each workshop is essentially 2 tutorial classes combined. So you will have 2 teaching staff in your workshop. But if you're not attending the workshop, that's fine, but you can still communicate with your teaching team and the other people in your workshop through that Padlet discussion forum. So yes, you will only see one Padlet discussion forum, because that's the way, otherwise there would be, there would be 30 odd different discussion forums. And if when there's one discussion forum for nearly 800 people, it's really messy. It's not easy for people to follow. So yeah, please do use your discussion forums. And look, as far as communicating with everyone, if that's something you really want to do, then either these webinars here is when everyone can see what you're typing, or the Twitter hashtag is a forum where anyone you can communicate across the whole 800 students who can view anything that you put on that hashtag for this unit on Twitter. Okay, guys. Well, look. So I'm going to actually close the meeting now. Close the webinar. In the absence of any other questions right now. Okay, so thanks again. Really appreciate your understanding, but also for your questions and for your engagement. It's great.